Good evening. Welcome back to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist working in southern Vermont.
And my name is Robert Stack, and I'm a licensed alcohol and drug counselor and a licensed mental health counselor. Good evening, folks. I want to take this moment to remind everybody that, you know, we have a way that people can send us messages and comments, and it's really helpful for us to understand what our audience is and who are we talking to. So I'm going to say it one more time. If you could send your questions and comments to letstalkaboutmentalillness@gmail.com, or you can text us as 802-490-3590.
Right. And we also have a Facebook site at facebook.com/letstalkvt, and it is cap sensitive. And Robert, I got to correct you. You said let's talk about mental illness. It's actually let's talk about mental health @gmail.com.
All right.
In case anybody picked up on that.
Well, that's why we haven't had any questions. Well, please, you know, if you have any comments or if you have any questions, you know, please let us know. Let us hear about it.
Right. And we do have a couple of questions that came after the last episode. So why don't we honor those queries and then start there. So the first question: has any thought been given to developing semi-permanent intentional communities for your clients? For example, could halfway houses or farm-based group living arrangements be superior in some cases to helping people normalize toward an independent living situation?
So I think this is, you know, from last week we had a segment on pathways, which is about getting housing for people with a severe mental illness.
Right.
And so it's sort of interesting because what it is, the risk is here, as you know, there was the institutions and there were the great state hospitals, and there was the movement to sort of deinstitutionalize patients and get them into the community. And now a lot of people have complained that there were not enough services in the communities for folks. And a lot of them have ended up now homeless, and some of them, a good percentage of them, end up in jails, and they're not getting their help. So it's almost like it's come full cycle, and now people are saying, well, maybe it makes sense to have people with severe mental illness in a community put together. And I think on some level, I mean, you know, there might be some truth to that. I think the concern would be always is that there's a tendency to want more people together in one spot to do it more economically, if you will. Yeah. And I'm sure that for some folks that's the right approach, but I'm not so sure about everybody.
Yeah, yeah. Because this is, I mean, as much as anything, a big piece of this question, it really does refer to deinstitutionalization, which happened back, you know, back from the 50s through the 70s, with the interest in treating people in the least restrictive environment possible. So the idea of having everybody with the whole spectrum of mental illnesses, from, you know, mental retardation through schizophrenia, bipolar disorder, and even some people really didn't meet the criteria for our established diagnoses now. It was sort of a one-size-fits-all treatment. There were a lot of abuses there, which brought a lot of attention to this. Also, the advent of effective medications played a big role too. And as we've seen with our current, you know, emphasis on pharmacology, there's been a feeling for a while that, you know, the medication is the cure or the route to wellness, and so a lot of times people with severe and persistent mental illness have been. The attempt has been to medicate them to the point of wellness, which isn't always an effective strategy. Mm-hmm. And two, there was the idea that closing down these state hospitals, that it was going to be economical, rather than having these huge sort of, you know, they were almost small towns all in and of themselves, right, with, you know, laundry services, farm animals, agriculture, that this would be cheaper as well to get people out in the community. And in the sense initially was, you know, more humane, right? Have people out there in communities living, you know, normal lives with normal people. But like you were saying, what's happened instead is a lot of people have not functioned well with the community mental health centers that have, you know, risen up to take care of them. And find people are homeless, they're destitute, they're in prison, so they're reinstitutionalized. So that idea of sort of moving everybody out of this one-size-fits-all institutions out to, you know, everybody's out in the community has left a lot of problems. And I think that just like we shouldn't have treated the full spectrum of mental illnesses with the one-size-fits-all of the state hospital institution, that this idea that everybody can function out in the community in something, approaching independent, living situation is, again, not a one-size-fits-all approach. So I would hope that we're going to start to see, with different means of treating mental illnesses outside of just medication, with case management, group homes, for example, that yes, we will have a broader spectrum of treatment rather than a one-size-fits-all, or meet people where they're at.
Right, and the question even mentioned halfway houses. And again, the question is, well, halfway from where? From where and where are they headed? You had that idea that they're in transition. Yeah. And I think a couple of times I worked with patients in the hospital, and I would say it's probably not a high percentage of them, but occasionally you would work with and you realize this person would do better in a more structured environment where people are looking out for them. Mm-hmm. And taking care of their meds, taking care of them, and they would really do well. At least you had that sense that they might do well. But the other thing that I think that has to happen is that, you were saying this before, that there's such a wide range of mental illness symptoms, and it happens in different times in people's lives. Right. And so I think in some ways the opportunities for housing need to be sort of fluid.
Yeah.
Does that make sense?
They
need to go from less restrictive. Sometimes they need more restrictive, and then they need to be able to get out of there or get stabilized and find another living situation. Right.
Yeah, and it has to be very dynamic. It has to be a very dynamic system, because there's not going to be, just like one size doesn't fit all for a type of treatment. Treatment is going to vary across the lifetime as well, as the illness is going to wax and wane, or relapse and remit, as we say. In which case, then, what is a good setting for me today, in a month or a year, it might not be a good setting for me then. So there had to be various levels of care built into that too.
And one last thing, and I just mentioned that in the question they mentioned about farm-based group living. As you know, the hospital up the road here had a farm, and it was sort of self-sufficient. They had cows and pigs, and the whole thing going. And then at one point, I think they sort of made it against they couldn't use anything from the farm to get to the patients.
Okay.
And there was this divide, and there was and eventually, the hospital had to sell the farm, and they sold the farm to someone else. And I think it's well-meaning. People have the idea, well, we can get them working with animals, working outside, and there's probably a segment of the group that would be ideal for. Yeah. But it's really not the answer for treating mental illness. I guess that's all I can say. I mean, I can see how maybe you would have this romantic idea about, well, we'd have cows and chickens, and we do this and we do that, and this would be ideal for mentally ill. Well, I think no. Yeah,
but I know that there are elements that I personally have liked about this too, and I think that maybe what's happening is when the system is not working, then we have a tendency to be nostalgic about the way it used to be. Back in the day, things were much better. So-and-so had a job, they had a purpose, now they're wandering around the community aimlessly. Let's agree, that is not good. So it serves a certain purpose. I think the key points here are that if we're going to be happy human beings, whether with mental illness or without substantial mental illness, that the things that keep us satisfied and happy are, one, we have to have a sense of purpose. Right, so we wake up and there's something to do and something that's worthwhile for us, and two, a sense of community or love, even if you want to go that far, like family, partnerships, and friends. And I think that for many people, what these arrangements did, the farm-based or the halfway houses, it gave one a sense of community, which I think is very, very important. So if I'm isolated, living by myself, and I'm struggling with mental illness, I'm less likely to be satisfied in that way. And so coming to something with a group would give me that community that could help me be happier. Right. So so there's elements here that are important, but nostalgia is, well, it's probably nostalgia for a reason.
Well, you look at it though. I mean, not to get too silly about this, but if you go all the way back to the 18th century, there was a time when farmers used to take on mentally ill as laborers, and the idea of the Brattleboro Retreat goes back to the York Retreat, and it was a Quaker notion. It was a place to give them better care, not have them farmed out as farm animals, as workers, and a place to give them care. So I mean, it is it's interesting how these ideas come back. And I guess, you know, we'll finish up with this. I mean, on one hand, you say there's a intentional community, and at the same time talking about moving out to living by themselves. Yeah. And, you know, I remember I lived on a commune for a while, you know.
That's right, yeah.
We talk about, you know, when everybody gets old, we all come back and live on the commune. It's sort of like, you know, this might be a good way to live, you know. So, but that's, you know, it's really different. I mean, it's hard to know when you think about individuals that you know with mental illness or what works best for them at this point in their life. And you have to take a look at their medicine, you have to take a look at their medical problems. And so it's really, I mean, I think complicated is an understatement, but there's no easy answer to it.
And as you were talking about sort of the idea of the, you know, the York retreat, you know, moral care in pastoral settings, what was the key to that was the outrage over how poorly and cruelly people with mental illness were being treated. So the idea of this sort of like a state hospital setting was an improvement. There was a kindness to it and a respect that was part of that. And then we found out that, well, that was either no longer in existence or there had been enough changes that this was no longer a compassionate form of treatment, and hence deinstitutionalization. And maybe we're at a point again where we're looking and saying, you know, this is maybe not the most compassionate treatment for mental illness, and we need to rethink what we're doing. And maybe these sorts of things like, you know, halfway houses, you know, farm settings, that they might be the right thing for some people. Yeah. There are some places like that right now that are sort of more, you know, farm-based, you know, rural sort of settings. So it is something that's worked for a number of people for a number of years.
Yeah. I mean, it's sort of, it's like the penitentiaries, you know. It was a Quaker notion that pretty much rather than flogging him or putting him in, you know, you would give them a chance to do penance, to think over what they've done or think over what's going on in their lives. And that was the birth of the prison system, of penitentiary. Okay. So it's sort of like, you know, it's like these things lose their purpose almost. Like you have this really nice idea, and then they get too big. They change the way they are. So anyway, I won't mess this up anymore. But it's just that idea. I mean, I like the idea of setting up smaller communities for some folks. And what's the best setting? Where to do it? Maybe do it in town. Maybe do it in the country. Maybe do it at certain periods of their lives. That some people would be horrible to. They enjoy being part of the town, part of the city. Other people might enjoy, you know, working with animals. But it's very hard to sort of put that into a bureaucratic system, if you would. Yeah. I mean,
which seems to be the way of the future for so many things, whether it's manufacturing, businesses, smaller, lighter, flexible, more individualized. Right. Yeah. Maybe mental health will go the way of
we'll see what happens
as
this goes on. Okay.
So another question then, please explain the changes to Suboxone treatment that started January 1st, 2014. So that's a rather general question.
Yeah, and I'm not sure about it. I don't know what the changes are, other than I understand there might be more people who are eligible for care. Is that true? Or is
well, I'm not sure. You know, thinking about Vermont, I mean, a number of people that I work with have various Vermont Medicaid-based programs like Vermont Health Access, you know, the VHAP and Green Mountain Care. And for them, I've always said, wow, you know, you have a great insurance. You know, Vermont's been at the forefront as far as, you know, parity goes, and these have been excellent insurance programs for folks with both addiction and mental illnesses. So January 1st, and what I think about when I think about January 1st is that then we have gone over to the health exchange. We were supposed to have converted over with the Affordable Care Act to our new insurance plans. You know, the state has this health care exchange, which is an idea as a stepping stone towards a single payer system, so that we can then sort of compare various programs and then get everybody insurance on the way there. So right now, my understanding is that people who qualify right now for VHAP, about 80% of them will still meet the income requirements to transition over to the next program, because VHAP and Green Mountain Care are no longer going to exist. there's going to be another program that they're going to meld into. And it's maybe, I forget how many folks from Green Mountain Care, but from VHAP like 80–90%. So a large number of folks will convert over to these similar system of care, so nothing should really change there. And then some folks are going to then have to basically sign up for other insurance, which in Vermont, I think the plans are through Blue Cross Blue Shield and MVP, and they'll be paying a premium and have a more sort of traditional insurance program, I guess you could say. So that's going to cause some changes there. So if that's the idea behind this question, then I hope that...
I think so, because the question was, I think, came in before Governor Shunlin's address, the State of the State address, when he focused on opiate treatment. And you know, I was very happy, and I said this when I was interviewed on the 545 Live with Roland. You know, I was very happy that he put the spotlight on it. I mean, I was very pleased with him, you know, and I was, you know, like, this is a problem. This is a problem not only affecting Vermont but other states. But this is something that, you know, we could probably have rather talking about, you know, accomplishments, or we're going to fix the roads, we're going to do this, we're going to do that, we're going to put, you know, he picked one type of important, one that affects everybody in many different ways. And let's talk about it, and let's address it aggressively. So I was really pleased with Governor Shunlin's approach. And what that means as far as treatment for opiate, people struggling with opiate addiction or opiate dependency, I'm not sure. I don't know how. I know he made some suggestions. I know he has some ideas. And as far as providers, he talked about cleaning up the waiting list. So I'm not sure how that's going to work. I haven't seen the details.
Yeah, and maybe if that's what this question was about, then we'll go into that next, because that's something we're going to talk about as a current event too. And of course, if none of these sort of approaches about the payment system with insurance care and these things about the governor's approach and the state system are the answers to this question, then please you know, write back to us and let us know more specifically. But there have been some really impressive changes in the state of Vermont around treating addiction and primarily opiate dependency. You know, one of the things we struggled with quite a bit just a couple of years ago was that the system was very fragmented, and nothing that was just characteristic of Vermont. This was throughout the country. I mean, it was so obvious that even you know, George Bush, as president, made mention of a fragmented mental health system throughout the country. So the way this played out for addictions in Vermont was that you had a smattering of methadone clinics. You had you know, a smattering then too of primary care doctors or psychiatrists who were prescribing Suboxone, which is another treatment for opiate dependency. And you essentially got treatment based on what was available near where you lived, or if you could travel, you know, greater distances, whatever you could get to. And well, when you look at, you know, treating illnesses, you don't tend to look at what is available in your backyard. Right. You go to a hospital, you go to a primary care doctor, you expect them to have the full range of treatments for whatever your illness might be. So the state has gone to, and they've rolled this out, maybe that's part of the January 1st question, they've rolled this out in steps in various areas of the state just to make sure that they get it systematized. And they're referring to it as a hub and spoke system. So the idea is that, you know, medications have become an important part of opiate dependency treatment, and that the two medications are methadone and Suboxone. And based on sort of the history, the development of these medications, you know, methadone has always been dispensed, as we say, out of methadone clinics. So a primary care doctor would not be able to prescribe methadone for opiate dependency. They can for pain, but not for addiction. So that was always in a methadone clinic. So patients have to go to the clinic, get their dose, go home, and do that every day. And then they can get to the point when they're doing well where they can earn what are called take-home dosages, so they might get to the point of showing up to the clinic once every week as opposed to every day. And this is when Suboxone came out. Suboxone treatment is by prescription. So you could go to your primary care doctor, was the original intention, and he would write a prescription for Suboxone, and you would take that, And so you're no longer in withdrawal, you no longer have the cravings, which is the same idea with methadone. And so the idea was then that this could be done in the community as opposed to at a clinic. So it was a milder level of, it's a less toxic medication. Suboxone is a much safer medication. And to have this taken care of through your primary care doctor is much less sort of intensive or intrusive way of treatment. See your doctor once a week, see your doctor eventually once a month, versus going to a methadone clinic and having to show up to the clinic every single day, and maybe getting to the point where you could go to the clinic once a week. So unfortunately what had happened around this was then the medication got attached to your sort of say social stability. So for example, if you're, again, usually in medicine what we do is we take the less toxic medication first, and then we work up to stronger and more toxic medications. So in this case, that means sort of, no medication, then trying Suboxone, then trying methadone. But if you had let's say if your social situation was very unsettled, you're unemployed and you were homeless, then you would automatically be sent to a methadone clinic because you didn't have sort of the stability to manage the medication. We'd be afraid you would misuse it, that you would sell it to pay, buy food, buy housing, and so you would go to a methadone clinic. So now what we realize is, well, even if you're in this situation where your life is really in disarray, you don't have a place to live, you don't have a job, but it's your first time into treatment, something like Suboxone should still be available to you because this is what we do in medicine. It's your first time, you should have a milder medication. So with this hub and spoke system, what the state has done is now in the hub are your methadone dispensing, but also now using Suboxone. And what the hub offers, instead of just sort of, one type of medication, it offers a whole array of services. So in a way, it becomes a health home for addiction. So if people are struggling with all these issues that I just mentioned, then they could come to the hub and get either one of these medications and get some case management and referrals and help around the medical issues, psychological issues, psychiatric issues, and that way start to be stabilized. And then once they are stabilized, then we go out to the spokes. Again, the idea of like a wagon wheel, right? A hub in the middle and the spokes out to the edges there. And so they would be stabilized there at the hub, and then they're sent out to their spokes eventually. Or if you're quite stable starting, you would start in a spoke. You'll be your family practice doctor. You say you have a job, you have a home, you don't need that level of care. Then you start there. So like we were talking about earlier with this whole sort of a spectrum of care, not one size fits all, not super intensive, not super lax. The idea of the hub and the spoke is then to have patients be able to, with their, not just physically, but like going to the hub office or going to spoke office, but service-wise too. Greater intensity, lesser intensity, and this way have a more flexible system that has a broader spectrum. And to have these hubs in 5 locations in the state so that it'll be more broadly available to all Vermonters with opiate addiction.
All right. And then the other thing I like about his talk, and thank you for that, explaining it, is that, there was always this idea that if we provide opiate treatment in a community, it will attract opiate addicts somehow, And I think, excuse me, I think people have come to realize, and by the governor saying, it's sort of interesting in Vermont, there are people who are acutely aware of the opioid problem, and there are people who are not aware of it at all.
Right.
Really, like they, for whatever reason, like if someone that you know or someone you love or your family or in your, you're aware of the opioid problem. You go, oh my God, this is, where do I get treatment? How do I get treatment? Who pays for it? But if you're not, you could sort of not, you'll see the item in the newspaper, somebody got arrested for this, somebody got arrested on the highway with 63 bags of heroin or something, but it's sort of, it's removed from most Vermonters, or at least they think it is, until you actually realize that, no, it affects everybody. And this idea, I remember interviewing clients, and they would tell me where they live, and as you were saying, I would say, gee, that's so funny, because there's nothing there.
Yeah.
Before we had a methadone clinic, people used to travel all the way down to Greenfield. Yeah. And we were sending people down there, just back and forth, paying for them to go to methadone. And finally, someone convinced the legislature, listen, we have an opiate addiction here. They're going out of state. It's very expensive. please, let us have a methadone clinic. So we did, and within no time there was a waiting list. I mean, there was literally 100 or more waiting to get these slots, as you know.
Yeah.
And it's been an uphill struggle because I think on some level, it's, I don't mean this like because it's a misused word, but it's almost as if some Vermonters, some folks, were in denial about it. And they really didn't want to think that there was that many opiate addicts. They didn't really want to realize the fact that we needed services for opiate addicts in all our counties. Not just in Chittenden County, not just in Burlington, not just, one spot or one over here, and that it was a problem that was affecting the whole state. So again, that's I think probably the most positive thing I liked about Governor Shulman's state address is that it's a statewide address, and he was saying it's a statewide problem.
Yeah.
And we need to have a unified, like you say, and we need to understand that there are people who are, I know that they have great hopes that they're going to tie this in with the court system, that they're going to be able to identify people who are in legal problems because of their opiate addiction, and at that moment, use that moment as a moment of, boy, I'm in trouble, I regret what I'm doing, and if I knew a way out of this, I would take a way out of this, and that they would be appropriate for getting someone help.
Yeah, I don't know if serendipity is the right term, but there's a moment, this magical moment, like, oh yeah, now I want to make make a change, and
I don't know if that's going to work.
I thought that was kind of. I was wondering. I was wondering who was advising him on that piece of the speech when he talked about when the blue lights are flashing and you see them in the rear view, that's when you want to get some help. And I can see, we believe in mental health that one of the principles of treatment is that there is you should be no wrong way in,
right.
And that the fact that you are there, no matter how ready you might be genuinely to make changes, is an opportunity for us to help you get better. But as we were talking about before the show, preparing, that we've known a lot of people come into treatment and, hey, what's bringing you? Well, I have court, I got arrested, and but I would have been here myself, right? But that's the thing that happened, and that'll be one of the challenges for us if this system gets going, because a lot of people come into treatment not because they think they have a drug problem, but because they have a legal problem, they have a parole officer problem, they have a wife or husband problem, they have a supply problem, right? I got more money, I've sold everything, I can't get drugs, maybe I should try this Suboxone or methadone program. So what I've often found, and this is just my own little thing, but getting kicked in the teeth is one thing to get you to enter treatment. And pain and negatives are one thing to sort of get you to move towards change. But I think the thing that really sort of keep people engaged in this is if we can show them that life is going to get better, and they're able to sort of look forward and to sort of pull themselves towards having a good life, again, that's in community and purpose, and those things sort of pull them away from the poverty and the trauma and experiences they have as addicts. So,
my only concern, and I've said this with Roland on this show, is that it takes a long time sometimes. People who are involved in recovery, there's relapse, and I just hope we're making a commitment of resources, but a commitment of time, of patience, and tolerance. That this is not going to be solved one time, and this is not going to be solved right away.
Because there's a component of not my backyard around treatment too, that people need to realize this is an ongoing effort.
Right. Next week, we're hoping to have John Moran, who's a legislator from this area, and he's on the committee up there around government, and a good friend of mine, drug and alcohol counselor, and we hope to have him here. So if you have any questions at all about some of the legal issues or some of the things that are coming up before the legislature, please send that information into Let's Talk About Mental Health at gmail.com or text 802-490-3590.
Or reach us at Facebook at facebook.com/letstalkvt.
All right, and again, we want to thank everybody who's been listening. We enjoy doing the show. Thank you all very much.
Yeah. Thank you. Good night.
Ready? 1, 2, 3.